Oh, back pain is a fact of life. It just occurs. I don't buy that. That is just a person who keeps repeating the same mistakes.
Stronglines had the privilege of catching up with Professor Stuart Mcgill, who's the director of Backfitpro. He's the leading mind for all things back pain. His life's work is nothing short of extraordinary, and we're a huge fan of his work. He continues to enhance the way that we treat back pain patients for the better. He's the author of many books, including The Back Mechanic and The Gift of Injury. And we discuss everything from the myths of non-specific lower back pain, from sloths to warriors, and what Professor Mcgill would do if he was Prime Minister. Enjoy.
Well, it's my absolute pleasure to first of all meet you, Professor Stuart Mcgill, and want to thank you for spending the time with us to enlighten us and help educate us as clinicians and our patients as well.
Good morning, Fred. I think it's evening for you, but
it is indeed.
Yeah, good morning to you, sir.
Thank you very much. So there will be lots of people at home who would like ideas in terms of how they might be able to help themselves, people who've had back pain for many years and find it quite difficult to either live with or stay active with it. So so that we can give a few people those ideas, how they can wind down their pain triggers, and perhaps modify their own movement patterns. As a back pain person, what can I do to help myself?
Well, each person is an individual, so the answer is it depends. Now, let me give some context for that. It depends beginning to the answer. There's no such thing, excuse me, as non-specific back pain. It's all very specific. So if you can begin a conversation with that person and ask them, what makes your pain worse? What activities aggravate your pain? And if they can give you an activity, it's not non-specific. It's very specific, and they've already begun to realize that there are certain things that sensitize their back or outright cause injury. By the same token, if you ask them, what are things that you tolerate well, or maybe even get some relief from? Now they will give you the antidote. So right away, this non-specificity starts to leave the whole conversation, and then doing pattern recognition, you can then say, well, I will bet that you, with the pattern you're describing to me, you get pain first thing in the morning, and then you ease out of that morning stiffness. You hit a sweet spot, and then if you do gardening or drive your car or sit at the computer for a long period of time, your right toe goes to sleep. So there would be a pattern. I would bet $1,000 that that person will have a dynamic open fissured disc bulge. If it's a right toe, it's on the right-hand side. If it's the big toe, it'll be the fifth lumbar root. In other words, that will be the bet. Then we leave the conversation, which is the initial interview, and we go and do the physical assessment component. So we're assessing anatomy, neurology, biomechanics, et cetera, and then we will figure out what's their learning style, how am I going to coach this person, what are the impediments, because they've been conditioned to fail. So what caused them to fail all the previous attempts? So, you know, none of this is random. Okay, that's the ideal. However, now that person comes to you and they cannot find a clinician who can operate that way. So I was motivated and requested to write the book Back Mechanic, which I never in a million years thought I would write for the lay public. I'd only ever written textbooks for clinicians prior to that. And so I had to start the book for the lay public with, here are some basic patterns. You may recognize these in yourself. It's all very specific. Now, here are 9 tests that you can do on your own to at least start subcategorizing this non-specific pain into something quite specific. Now you know what to do and what not to do. And then we show them things like movement hacks to move around their pain triggers. We show them how to strategically organize stability, stiffness, mobility in their body, and spare the painful mechanism, allow it to desensitize, and build a foundation for pain-free activity. So there's the full spectrum. Go find a competent assessment, which is going to be difficult, particularly in the UK. That's not an indictment of the clinical community, by the way, but it will be hard to find a person who really understands back injury and pain. But short of that, I'm sorry about this, but follow back mechanic.
I really like that that phrase you use, those movement hacks, in terms of finding maybe a different strategy or a different way of managing the load, modifying how you use your body, where you're putting the stress or the strain, or where the movement's coming from or not coming from. And often, yeah, you listen to the subjective, and you try and find those clues, those little breadcrumbs that lead you towards a fairly rough idea of what's going on, and then you can probe into there in the objective.
Here's a very fast example. So I can sit on a stool and I can sit upright, and I might ask the client or the patient, whatever they are, is this triggering your back pain? And they might say, no. I say, good. Grab the side of the seat pan and pull up 5 kilo on each side. Does that change your pain? No, that doesn't change. Good. Drop your chest down a little bit. Oh, yeah, there's my pain. So I've just proven to them that posture matters. Or another person I might say, extend, become a peacock, lift your chest. Oh, yeah, there's my pain. Good. Move your head up. Oh, yeah, it's worse. Oh, that took my pain away. In other words, to play a little game of, posture migrates stress. That's what it does. It moves the load bearing to muscles, onto different ligaments, onto different structures, and you will find the one that is sensitized.
And then that gives you your whole rationale, doesn't it, to building quite a specific rehabilitation program for them. It's and what a powerful tool as well. If you can prove, yep, there's your pain, okay, it's gone now. What a powerful tool to kind of give that rationale to the patient as well and educate.
Well, there's so much talk these days about the psychological and the social correlates of back pain. If you can take a person's pain away and show them, when you do this, you just control all your pain, that is so self-empowering. The person just says, why has no one shown me this before? I feel fabulous. Instead of being fearful of the pain, they say, oh, I just triggered my pain. I know what I did. I won't do that anymore. And now pain becomes the tutor, which is what it's supposed to do in the first place, before it got messed up with all of these ideas that the person has, mental issues. No, actually, they just need to be educated.
Well, there's a lot of people who've come to us who are at the end of their tether, and have been told that horrible thing. Yeah, it's in your head, or it's only a pain issue, which can happen, but it's rare. But yeah, it's just that maybe nobody's listened carefully enough along the way to say, actually, why don't we try doing this first, rather than just hitting it blindly with tools that don't necessarily fix the patterns or add strength or endurance. So that kind of leads us on to the next question there. So we're incredibly biased, and you can see our little setup here. We're very biased towards sort of using strength and conditioning techniques and principles of training in our rehabilitation, which might be surprising to a lot of people, but in the UK, that doesn't happen that often. For people who kind of think they've just got a dodgy back and just have to live with it, what would you say to those people if they're just sort of ticking on, thinking, I've got a bit of a dodgy back, I just won't do that activity?
Well, they haven't found the right clinical expertise yet. Or I've heard other stories, I've been going to see this clinician for 20 years and I just keep going to see them, and I say, well, good for you. You just bought them a new Mercedes, but what did you get in return? And my thought is, I'm going to use the word disgraceful. It's disgraceful that that person has now languished and never been empowered with the education and understanding of what is causing their pain, which came from a very thorough assessment, and given them a proven approach that might have several layers and components, and it might not be easy, or it might be dead easy, I don't know. But it's a disgrace that that person has gone through maybe 10 different layers of clinicians, and no one has ever shown them the cause of their pain and what to do about it. You know, I also would put this back on the clinicians. When I ran the experimental clinic at the university, we followed up with every back patient we ever saw through my entire career. I know exactly what my clinical score is.
Wow.
I know who we did well with. I know what the subcategories of back pain that they were put into. I know whether they complied or not. Maybe they were addled on opioids and they can't even remember coming to the university. I know how they were 1 year later and 2 years later. So as I said, I know exactly my score. I don't know of another clinical group in the world that has followed up. So a patient stops coming to them. The average clinic would think, oh, well, we got that person better. They never came back. No, actually, they got worse. But you never found out, and you didn't know. So the mistakes are repeated.
I know, skipping ahead slightly in terms of the questions there, leading on to how might you design the sort of perfect healthcare system, as it were, for back pain patients.
So you mean if I was the prime minister of your country, what would I do?
Maybe, yeah.
Well, have you ever heard of non-specific head pain or non-specific leg pain?
Yeah.
No, the person receives quite a thorough assessment, and the intervention approach is matched to the specific cause. So that has to occur with back pain. So the first person that sees the back pained individual needs expertise in low back pain. Now, who is that person? It's not the psychologist, and it's not the person who uses ultrasound. It is a person who has knowledge of mechanics, physiology, psychology, anatomy, neurology, etc., all rallied around the low back. So when that person comes in, they can read that person right away. You are seeing pattern after pattern forming, and you will know, and you start forming hypotheses to then lead your assessment. So would you give the same assessment to your 75-year-old mother than you would to someone who's one of your colleagues? I hope not. So even the assessment itself has to be tuned to the person in front of you. Then you decide on what the most revealing, we call it signal to noise. What will give you the greatest signal and truth and understanding from that person versus all the noisy stuff? Well, that again is very person specific based on their age, how many miles they have on their body. Are they a sportsman? Are they a sloth? Are they, do you see what I mean? And then choose that most appropriate assessment and really have the skills now to figure out what motions, postures, loads, and activities are triggering the pain. What of those four take the pain away? Now you start boiling it down to the tissues. So, there's this discussion all the time, well, MRIs don't show back pain. Of course it doesn't. An MRI is a picture. So if I took a picture of your face or my hands, you'd see all sorts of scars all over my face. You'd see them on my hands. You're looking at the full life experience in this face and these hands. How do you know which scars are causing pain? But what are the fresh wounds? Now, if I had a bleeding tendon cut and it was hanging out, you would say, well, that's a pretty good bet. That's what's causing my pain. So the MR, the clinician has to determine, is this a wound that's fresh and causing the pain, or is it an old scar that's no longer painful? But the radiologists How many of them examine the patient first? Zero. They have no
Yeah.
context for reading the MR, so they don't know what's a wound and what's a scar. But we had a full radiology suite in our clinic. So we were able to create one-to-one matches between what assessment features get us or allow us to predict. You have the pattern of an open fissured dynamic disc bulge at L4. It's why your little toes are falling asleep. And when you bend forward, and then we look on the MR, bingo, there it is. It's a one-to-one match. So all the other features that we see, we know, we test them. We remove them. They are not candidates for causing the pain, even though they're features on the MR. So anyway, so getting back to what, if I was your prime minister, have a entry person to start that off. And now they can say, well, you're a CrossFit athlete. Here's a pattern for you. Have you ever met a lazy, slothful person in the CrossFit community? They don't exist. They're all keeners. They're wonderful people. They rally around physical exercise, but dollars to donuts or pounds to donuts, those are the people you have to hold back a little bit. They're overdriving their biological system. But the next person comes in and they're basically a sloth and they need more activity. You don't need to hold them back. You need to do precisely the opposite. You need to encourage them. Now, what do you need to encourage them to do is the next question. Is it short interval walks? Is it longer walks? Is it coming to do kettlebell swings? So do you see it? That's why we have to train our own clinicians. But anyway, if you had that entry assessment of the back pain person, you would save so much money in your NHS. So instead of paying clinicians to perform procedures, so depending on your training as a clinician, you have a certain number of clinical tools and expertise set. Those have billing codes. They bill your NHS for performing those procedures. No one is at the front end to say, that's the procedure for that particular patient. Yeah. So it's trial and error. And at the end of the line, they haven't found the right intervention for the right pathway to pain. And then the pain clinic comes in and says, you're magnifying your pain, or your tissues should have healed in your back 12 weeks ago. Any residual pain must therefore be psychologically modulated. And then now the person, the pain is in my head. Do you mean I'm crazy? And so, you know, I do know that cognitive behavioral therapy helps some people, but don't believe it helps all. I get the ones who aren't helped by it. Some of them come suicidal. They are ready to take their own life. They could live with back pain, but what they can't live with is they have a mental issue that they can't control, and somehow that this is causing their pain. And that's the thing that drives them suicidal.
And that's, as a clinician and as a human, that's something I can, maybe not as far as suicidal, but certainly relate to when I had my own back injury when I was a youngster, training like a absolute insane person. You wish you could sort of step back and say stop. But yeah, that history of that initial injury that causes then this cascade. And like you say, if you look on an MRI, you're seeing a scar, but then that has a knock-on effect to the surrounding tissues and the movement patterns that kind of build up. So then this pain or this aberrant movement occurring at that segment then just kind of proliferates and gets bigger and bigger and bigger until you can't, it's not something they necessarily see on the MRI or that you can attribute to obvious mechanisms, but when you, what we can show us here. Yes, please.
You will never see this on an MR, but it's a very, very common pain pathway. Most people in the back clinical community don't recognize these. It's micro movements. So, you know, when you let a little air out of your car tire, the tire bulges, and now the car is sloppy on the road. Injury does the same thing. If you lose the integrity of a knee ligament, you now have shear and stability. A drawer test will show you that that's the pain trigger in an ACL deficient knee. So we do drawer tests on people's spines to locate the level of this loss of normal stiffness. So all of these models are built from, but they're produced by a company called Dynamic Disc Designs, but they're built on injury mechanisms that we were able to prove over the years. So consider this disc is normal and this disc is normal, but this middle one, L45, the end plate has been damaged. The pressure in the nucleus inside is a little bit less, so we've lost a little bit of stiffness. Now I'm going to bend and apply moving torque. Do you see how the majority of the motion occurs there? Yeah. Not at these two. So the pain pattern is, oh, for a while they've got numb right toes, and then later the pain moves to their left flank. They've got micro movements. It's not a stable pain pattern. It moves around. Yeah. And people say, oh, well, you're magnifying your pain. No, bloody hell not. They've had a little bit of damage to a joint, and those micro movements are now triggering this differential pattern. So what do? You now create a muscular girdle. You know, it's not drawing your abdominals. That's the worst possible thing you can do. Poke your fingers lateral to the navel, in, now push them out. Now repeat. Can I now move without that triggering movement catch? Oh yeah, thank you, my pain has gone away. Or have the person stand tall, completely relax, be a slob, don't activate anything. Bounce on your heels. Oh yeah, there's my pain. Good, push my fingers out. Oh, my pain is gone. Or the person might say, oh no, my pain is even worse. There was a compressive penalty to creating that particular stiffening pattern. Okay, change it. Externally rotate your shoulders, pull down with your pecs and lats, leave your belly alone, and repeat. And then they might say, oh, that took my pain away. That was the secret sauce for my individual pain trigger, which won't work for you or anybody else. But the skilled clinician probed their system, identified the mechanism, and honed in with precision on a intervention that made them robust. You just changed their life. You've empowered them with an actionable plan, and you watch the smile come back on their face and their psychological dissonance evaporate.
I think I remember you talking on a podcast, might have been with Eric Cressy, that you had a room full of clinicians observing you conduct your assessment, and you had a lady there who had been told she was going to be committed to going into basically into a care home because she couldn't handle with her back pain, and you immediately gave her a couple of bracing strategies, and she was rising from a chair pain-free, and instantly changed somebody like that's life.
Well, I know the story that you're talking about now, and it was in the UK. I was invited by a medical school to see 3 patients in front of all the staff, the surgeons, wow, the fellows, and whatnot. And this woman came out on stage, and she was very mentally distressed. And I said, well, tell me your story, and how can I help you? That's all I said. She never mentioned her back pain. She was crying. She said, well, the physical therapist told me that when I get up off the toilet, they're afraid I'm going to fall, and now I have to leave my home. And I'm not afraid of falling. What I am afraid of is no one will find my cat and feed him. And I said, oh, really? Could you stand up and show me? Pretend that's the toilet. And she got up with the most incompetent squat. And so I took the time to teach her what you know very well. Go down. Now in North America, we would call this the baseball shortstop posture, but in your country, you might say, I'm playing outfield in the cricket game.
Yep.
Good. Now let's nuance this a little bit. Let's shape the curve of the back. Oh, no, that causes my pain. Good. Find a shape in your back. Is that pain-free? Yes. But you're shrugged up. Anti-shrug. All I said was anti-shrug, and she gave me a perfect latissimus pec major activation. But it's a coaching cue, anti-shrug. Oh, I got that. You're a leaning tower. Lean forward through your ankles. Push down with your toes. Good. Now don't lift with your back. Push down and pull your hips through. Perfect. She did it again. And she did it again. And I didn't say anything. And I said, good. Spread your legs apart. Move your hips back and sit down using that same pattern. And I said, now stand up. And do you know, she spread her knees apart. She got her feet underneath her. She had a determined look on her face. She lifted her chest, moved forward through her hips, pulled her hips through and stood up. It was weightlifting 101. And I didn't say any more. And a big smile came on her face. And I said, what's up with you? She says, I don't have to leave my home, do I?
Amazing.
So that was such an indictment of what clinical experience she'd been through. And no one had assessed her. No one understood the mechanism, and no one had the skills to coach her basic movement, which was a 30-second intervention, but it was life-changing.
Yeah.
So don't talk to me about non-specific back pain and anything else until a thorough assessment has been performed. And I hope your Prime Minister watches you.
I'll call him in. People think we're just a gym here. And, you know, there's physiotherapy above the door, but they look in and see the squat rack and weights and things like that. But like you say there, it's weightlifting 101. You just scale it. You can take certain techniques from the extremes and scale it to the individual and find enormous benefit. Could you talk a little bit on your assessment techniques that you carry out at Backfitpro?
Yes. Well, a patient will email me typically from somewhere in the world, and I send them an information packet, and they get on an airplane and either fly to Toronto and rent a car and come on up, or a lot of them are elite athletes and they have their own private aircraft. So they will fly right here 10 minutes away to a small airport. And I pick them up and the assessment has already started. So the second I see how they duck under the airplane door to walk down the stairs, the assessment has started. I drive them back here, and there's a flat fireplace if I was to turn the computer around, and I just say, tell me your story. Now, if they're a celebrity, I will have known something about them just from following the news or the sport or whatever it happens to be. But I'm doing pattern recognition the whole time. And the assessment interview starts very free form. Just tell me your story. So I get a read right away. Are they talking about their family? Are they talking about losing their job or their athletic career? Or do they just get right into the pain? This causes my pain. This is what I need to do. I might trick them with clandestine movements. I might say, would you mind passing me that out of your backpack? So I'm watching how they bend. And so when they start reporting to me that sitting in front of the computer causes their pain, and yet they just replicated that only to a greater degree to cause even more of a pain trigger, I know the pathway to pain is not only hardware, it's software. So we move on habitual movement patterns. In neuroscience, they're called engrams. So you have an engram for moving forward. It might be adaptive or maladaptive. I don't know, but the point is that's your muscle memory. It's the same pattern. So if we go back to that idea that if that causes your pain, and I watch the person get out of the chair and the first move is into their pain all day long, they're hammering that pain trigger. So to then say, okay, well, let's spread your knees apart, sniff a little air. Bingo. And they just said, oh, I just stood up without a pain trigger. Well, that's not magical. It's 100% scientific. We've just alleviated the tissue stress. And it's actually tissue strain that triggers pain at the tissue level. And then there are truly those who are psychological magnifiers of their pain. So if that's the case, I will probe them. I will create pain in their body. I will play on their second rib. I will press on the mastoid process, just seeing what their reactions are all the time, or I'll perturb their back, and you will feel the flash of a neuromuscular compartment flash in pain, and you will perceive that. So when I'm training clinicians, I take a mustache hair out of my face, I put it under the first page of the phone book, and I ask them to find it. Just with their fingers. And when they can get to 3 pages, I know they're able to feel neuromuscular reaction to pain at just the most slightest little level. I don't have to ask them if they're in pain anymore. So the masters of the craft reach this level of sensitivity and awareness of reading the person. And then we go downstairs, and I have a patient assessment table in front of a squat rack with over 1,000 pounds of load on it, because I can think of about a dozen men who've been here who lift over 1,000 pounds. So I have to probe them at that level. So if it's your mother, we are going to be probing her at very modest levels of
She's very
challenge.
strong.
But okay, well, if it was my mother, a very modest level of challenge. But if you are the holder of the highest Wilks score in human history in powerlifting, I need to see how you squat 1,000 pounds. And they don't have pain during normal life. They have pain in the last 3 inches getting to legal depth in the squat in IPF, International Powerlifting Federation. That's the rules. But that's the component of their job that is causing their pain. So or it might be a mixed martial artist. I will have to have a little role downstairs and figure out why a particular jiu-jitsu maneuver triggers their... So do you see, the sky's the limit on this, but that's the process. Then we educate them on what their mechanism is, and then we show them how to engineer their life around that, allow it to desensitize. Then we build strategic athleticism. So if this micro movement was their pain, they need a muscular stiffness pattern, because in about 10 years, nature will stiffen that up. But it will take 10 years. Does that mean they have pain for 10 years? No. If they're clever and skilled, they will know how to manage it in terms of total training volume, in terms of avoiding fatigue, so their patterns break down and they get to pain. You know, think of the times you've hurt your back. You did it when you got out of form because you were tired. Anyway, there's a little bit of a start of when you say, what does the assessment look like?
Yeah, it's an interesting thing, because obviously you have at Backfitpro, you have the extremes. You have Brian Carroll who's tuning the spine for incredible stiffness, and then a jiu-jitsu master who I suppose needs different properties, being able to create stiffness, but also then incredible mobility as well.
Right. The previous podcast that I just did 2 hours before this one was to the yoga community. And you might be familiar with the yoga course that I did with the yogi Bernie Clark, Your Spine, Your Yoga. So my world is, people only come to me with back pain, but they might be a yoga master. They might be a jiu-jitsu master. They might be the strongest man in the world. They might be a king of a country. That's, but I also
pain's a leveler.
I did a podcast last week where they were asking me about personalities and that kind of thing, and pain strips people bare. And the king is the same as me or anyone in the village I live in. It strips you right bare to your core, and people are people.
Amazing. So a couple of bits in terms of how the body might respond to tuning. Can I ask about the sort of how disc collagen and the lamellae in the intervertebral discs respond to different types and intensities, volumes and frequencies of load? I know that's a thesis.
Yeah, well, no, it's a fair question. So the spine is not a section of ball and socket joints. So the hip joint is a ball and socket joint. It's made to create power, which is force times velocity, through a big range of motion. That's what a ball and socket does. But you'll notice these are not ball and socket joints. We couldn't have ball and socket joints in our spine because if I took a stack of oranges, which would be ball and socket joints, I couldn't put a book on top. It would just collapse. So if I had ball and socket joints in my spine, I would need such massive guy wires to hold that stack of oranges up. I couldn't move at all. So it would be a terrible evolutionary adaptation. So instead, we got discs, which add stiffness and define the range of motion. Now, the problem becomes when people start treating the discs of their spine, which is an adaptable fabric. It's not a ball and socket. So my shirt is a fabric. It's not adaptable, however. So if I create stress strain reversals, slowly the fibers delaminate. Well, inside the disc is a nucleus, which is a gel, and that pressurizes when you take load. That is contained by the walls of the disc, which are strands of fibers of collagen. One layer runs this way, the next layer runs this way, back and forth, etc. Now, if I keep moving the disc back and forth, slowly those strands delaminate. Not because of the strands getting loose, but because of what's called the ground substance, which is the gooey stuff that holds all the strands together. So I can work the gooey stuff into a more viscous, compliant stuff. So when I pressurize the nucleus and I keep moving under high load, the gel seeps through to create what's known as a herniation or sequestration or whatever the case may be. So lots of mobility is fine. If I want to go on all fours and do a cat camel, there's no issue because there's no load. But if I add load while I'm doing a lot of spine motion, creating high power, that causes delamination of those collagen fibers, and you have mobility, but you're losing the ability to sustain load and strength. So you hit the nail on the head. When you get a guy like Brian Carroll, who he squats close to 1,200 pounds, if you can believe that, you need supreme stiffness. They put on heavy suits and tighten them all up to add more stiffness, an exoskeleton of stiffness to add to all the muscles, because that stack of the spine, this flexible rod, if it starts to bend under 1,200 pounds, you're going to collapse. It's a car on your back. It's a big deal. You cannot change the thrust line more than 1 millimeter without starting the collapse, which you have to abandon the load or you get crushed, one of the two. So have you ever been to a powerlifting meet and watched the men and women come in? They wear Birkenstocks, sandals, because they can't tie their own shoes. They can't even scratch their own ear. So in terms of unidimensional athleticism, they are a highly tuned beast. They are tuned in their body to be stiff to bear heavy load. Don't ask them to do yoga. But the opposite end of the spectrum are the yoga masters who have supreme mobility. Now, they don't get disc bulges when a powerlifter bends forward too much and repeatedly delaminates the collagen. It's a posterior bulge, but not a yoga master. A yoga master has so much mobility worked into their spine, they buckle on the compressive side. So they get a disc bulge when they extend, quite opposite to the lifter's type of disc bulge. So you're asking me about adaptation, and I'm saying most people want the ability to bear some load and still have mobility. And I'm telling you that if you train the extreme, you can't have both. So if you want to be a yoga master, don't get under heavy loads. But some of them do. They're not a stay-at-home mom, they're just a mom and they have to pick up their kids. Back off on the mobility and you will be more resilient. if you get to extreme stiffness and you get back pain tying the shoes your skates up before you go for a skate at the hockey rink, you have a problem. And we have players in the NHL who don't tie their own skates. That creates a situation where they can have an acute attack on the ice. But if they don't, and if the trainer ties up their skates, they are resilient and playing at an ultra level. So again, it's managing and knowing where you are in this mobility stability, stiffness spectrum, and then we tune it. But there's no such thing as infinite capacity in terms of biology. There's always a tipping point. So know what your goal is, and then train to optimize that tipping point for you, and don't cross it. So your job is increase the tipping point and don't cross it. And that is the sweet spot for resilient athleticism. But it's different for everybody depending on what your goals are. But don't believe this myth that you can have everything. You can't.
Would you mind talking about the anatomical and structural variants that would predispose somebody to maybe being better at bearing load or being more mobile?
Yeah, there's a lot of them, actually. The first one is disc thickness or spine thickness. So if I took a thin willow branch, I could bend it back and forth. There's no stress at all. You could do that all day long. So you could have someone with a very slender spine, and they can do lots of sit-ups, they can do yoga, etc. No problem. Now, playing golf would be another example. A slender skeleton favors golf. Now let's take a very thick branch, not a willow, but a thicker branch. We're going to bend it to the same degree and it shatters right away, because the stress and strain in a tube is a function of the radial distance from the neutral axis. In other words, it's thickness. So if you were then to get a big rugby prop who has a heavy bone skeleton and ask him to do the same number of sit-ups, you have a problem. You've just created much higher stress by creating an equal amount of bend to a structure that's not made for bending. It's made for load bearing. Now let me ask you a question. Do you know of a golfer a rugby prop in the world who can hit a long golf ball? It's very difficult to find, because of the resilience and the athleticism are somewhat mutually exclusive. Now, there's always the odd athlete who's touched by the hand of God and does have a bigger spectrum than most of us. But in biological averages, that's a very rare event. So don't ask a golfer to play rugby prop. Don't ask a rugby prop to hit a golf ball. They're not tuned in their mobility, stability, size spectrum. So there's a little bit just on disc thickness. Yeah. The next one is, are you an ovoid or a limacon? So that is a limacon. Do you see how that disc is shaped like a lima bean? Mm-hmm. So when if you get a disc bulge, do you see there's a little bit of red growth from the vascular structures right there? So there's a lamination that occurred, but you noticed it was right at the tip of the limacon. Whereas if that was an ovoid disc, it would be more in the middle. So the shape of the disc also focuses, stresses, so that it's not a coincidence at all that you've got a rowing crew of 8. And I don't know if you know, I've worked with your Olympic program. You have a good one now in rowing. But isn't it interesting that if you're rowing port side on a boat, crew of 8, where do you think the disc bulges are every single time? Left side, because you're bent. So it's a repetitive cumulative stress. The bigger the limacon, the greater the likelihood of that occurring, you see. And also in terms of therapy, there's a philosophy in therapy called McKenzie directional therapy. It's absolutely magical for some acute discs, but the more focused the disc bulge, the better it works.
Yeah.
It will only work if you have 70% of the original disc height remaining or more. So I'm giving you layer upon layer now of features of that disc that determines how it will delaminate, What is its resilience to both load and motion? What therapies are going to be better suited to returning that disc bulge into the center? And, you know, I'm not talking through my hat. This was the experimentation that we did for 30 years, full time for 30 years, myself and our whole team, on trying to probe and investigate these questions. But there's a start on some science that governs, again, the great specificity of why some people get disc bulges, why they respond to certain types of things, etc.
It has key relevance, doesn't it? So if we're looking to try and return somebody, not necessarily to a sport, but to an activity, and looking for the cues in what they've been telling us, the cues in how they move, and then returning them to that activity kind of pain-free. What about in terms of the lifespan of the spine? So from this maybe taking into account young sporting individuals, and as they grow up, what impacts would that have in terms of training for the spine and the individual?
Well, I've been answering with very long answers. I'll try and create a shorter answer here. And I think I've already mentioned it in terms of know the tipping point, and your job is to create the right adaptations to extend the tipping point and don't cross it. So that's it in a nutshell. But that's a real art and science, to know where the tipping point is and then know how to use it up with the most effective training tools. There are other principles, though. Don't damage the end plate. So if you fracture an end plate and the nucleus leaks up into the vertebral body, quite a common occurrence. That person might see, oh, they've got Schmorl's nodes or end plate fractures on an MR or a CT report. They weren't born with those. Those are caused by crossing the tipping point in terms of compression. Yeah. So now you've lost the ability to contain pressure in the nucleus. The disc becomes a bit flatter. It starts to bulge. It applies pressure to the lateral nerve roots. The facet joints take more load. You might get kissing spines in the posterior here. I mean, it's a house of cards, but it depends on your anatomy and your chronic exposures and who your parents were and all of these things that will come together to give a very specific reason why that person has an issue.
It's key, isn't it, in terms of going back to the story. When you say to somebody, tell me your story, it depends at what point you're meeting that person in their life, and you know what their pathway's been, that continuum of maybe that initial injury of an end plate fracture leading to that dehydration, flattening, leading to that aberrant movement that then, you know, if you're picking it up later in life, it's then that the facet issue that might be there. It's key to get that whole story.
It is. You can imagine some of the stories. They'll say, well, you know, my pain has changed in the last 10 years. When I was a younger man, flexion caused my pain. And if I sat down in a business meeting, I couldn't stand it. But if I went for a walk, that was my cure. But I'm 70 years old now, and the opposite has happened. I can't take walking. Sitting is my relief. And then I show them with this brass rod. There's obviously an older specimen now with lots of our arthritic growth, and the facets are looking a bit gnarly. But the spinal cord is, I can get it to floss. There it is. And do you see the brass rod just falling out? Now I'm going to add just a little bit of flexion and I've grabbed the nerve. Or if I was to add a little bit of extension, now they're walking. I've grabbed the nerve. I've just changed the geometry that now I've caught it. But I'm going to add just a little bit of flexion, a little bit of pelvic tilt. Well, this isn't tuned very well, and there it is. So we show the patient why, if they adopt a slight little attitude in their back, all their pain goes away, and now they can stand to go for a half-an-hour walk, which they'd never been able to do. Or we might show them, just before you get to that painful point when you're walking, go up to the back of a park bench, put your hands in reverse, and anti-shrug down and let your hips drift towards the bench and stay like that for 40 seconds and then stand up. Oh, yeah, I'm restored. My pain is better now. Good, go walk for another 15 minutes or whatever. So, I don't know what the intervention will be, but the experimental process that guides the assessment will lock us right on with great precision what that person needs to do.
Could you show us any other examples of that neural tension?
There are many, 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 many. So there is the spinal cord in this segment, and the spinal cord is simply a rope, if you want to think of it that way. So I can pull a rope from above with cervical flexion or extension, and I can pull it from below by flexing my hip or extending my knee or pointing my toes or whatever. So that is causing the whole spinal cord to floss up and down. Now, if I was to create a disc bulge, so if you can just see that red mark right there, I'm going to flex forward and squeeze, and you'll see the bulge start to grow. And sometimes that's immediate. We'll watch it on MR and it'll be immediate. Sometimes it takes 15 minutes of slouched sitting. But going for a walk, within 15 minutes, it's now gone. But as that grows, you'll see how when I look down, watch the nerve root. Do you see how the nerve root gets pulled up into the offensive bulge? But sometimes it's underhooked. So now I'm going to place the nerve above the bulge. So when they look down, they get the opposite. And when they look up, it pushes the nerve down into the offense. So we'll know right away whether they have a traditional overhook or an underhooked nerve root. Sometimes there's just a friction on the nerve root. In other words, they do a cat-camel movement, and it's only as they move. Or if they were to do a pelvic tilt, it's only in the act of moving that's causing the friction. And they'll say, yeah, it's only when I really swing my arms do I get that central, creepy neural pain up my spine, or whatever it happens to be. There are yet more ideas. Sometimes post-surgical, you'll get little tethers where through the scarring process, a little tether forms on the dura or on a nerve root. Or sometimes you cannot find a reason why you are probing and finding a neural tension. A patient that I had not too long ago, they just couldn't sit in the car. They could sit on a chair like this and not get any neural pain. But what it turned out to be was as they flexed their hip, which stressed the sciatic nerve behind their hip, but when they had to lay out their leg to touch the floorboard, that added more strain on the sciatic root. And about 1.5 centimeters outside of the foramen was a Tarloff cyst. And that was the thing that was accounting for their pain. So again, it wasn't random. No one ever found it, but no one ever did the assessment to know. I bet that if I follow that nerve root along its pathway, I will find why it's getting hung up. When a patient has a Tarloff cyst, I don't have the ability to do anything about that. But there's a surgeon in Texas that we send our Tarloff cases to, and he has a wonderful track record. He has a procedure where he doesn't only deflate them, so to speak, but he then puts a wrap around them so they don't grow back. And we've had, our patients that we send there. So the precision diagnosis also helps us to refer on. There are some people who obviously we can't help, but we were the first person to find out what the mechanism was. So that goes back to your prime minister again. Don't let these people slip through the cracks, and they will be referred on to the person who has the expertise matched to their specific condition. And this idea that, oh, back pain is a fact of life, it just occurs, I don't buy that. that is just a person who keeps repeating the same mistakes and they get it 2 or 3 times a year. Think of your national loss in productivity. If they didn't have those acute attacks, which again, I've proven this because I've measured the efficacy of every patient. If they can stop those repeated episodes 2 or 3 times a year, you've just saved your country a lot of money in lost productivity.
Perfect.
So
Remember,
the competent assessment is worth it on so many levels.
I remember listening to you talk about how you'd experimented to see how cement might or might not work for Brian Carroll, who we talked earlier about. And you talked a little bit on, or would you mind talking a bit on the sort of bony callousing technique that you employed there?
Yeah, I'm obviously not in the clinic now, but I have quite a collection of all of these different pain mechanism pathways. And obviously, I wrote the book with Brian, so I'm not giving away private medical information here, but I do have a model showing the end plate fracture. So a surgeon sometimes will try and rebuild the integrity of a vertebra by doing what's called a kyphoplasty. So you put a small drill hole in the vertebra and you inject bone cement under pressure and it sets. So you're casting the bone from the inside out. So I tried that. But the problem with it is the cement keeps leaking through the end plate fracture because he'd split his sacrum front to back with a transverse fracture this way. So the only thing I had left was to, I was straight up with him. I said, we can try bone callousing and rebuilding the bone. I've only done it 2 or 3 times before, but you don't have any other option here. No one can operate on you. The damage is too extensive. L5 was heavily fractured, et cetera, et cetera. So now I have to tell a scientific story. Is that okay?
Yes, please. Yeah.
Okay. So you may have heard of Wolff's Law for building bone. How Wolff's Law works is, let's take a long bone as an example. If I put a 3-point bend in this bone, this surface of the bone goes into tension and this surface goes into compression. Agreed?
Agreed.
If you take a quartz crystal, so I don't know if you have quartz in England, but we've got lots of it around here. So if you're a kid, you get 2 quartz crystals. It's at night, it's dark, and you do that hard to the 2 crystals and lightning flashes through the crystals and they light up with lightning. Because a quartz crystal is a piezoelectric crystal. In other words, when you stress the crystal, it builds an electric charge. When you release the pressure, the energy release comes through in light. So lithium, you've heard of lithium crystals. They are a fabulous piezoelectric material. Your bones are piezoelectric. So they are built from charged ions of magnesium and calcium and these basic building blocks of bone. So here's the intelligence of your body and mechanostimulation. Let's bend the bone. How does your brain or your system know that that is the most stressed and that's where I need to build bone? Wolff's Law, you create a piezoelectric charge at the point of highest bone stress. That charge sucks in free ions of calcium and magnesium and chemically bonds them to the bone where the piezoelectric charge is. You got all this?
Yes.
Now, a bodybuilder is mechanostimulating muscle hypertrophy. So you train, you break down muscle, you actually damage it at a micro level, and your body reaction is to grow the muscle. We're kind of doing that with bone, although here's the failure. A lot of people try doing strength training, say a heavy, deep squat, like a bodybuilder 3 times a week. What happens is the micro trauma to the trabeculae of the vertebra, they get micro cracks in them, and they get a charge as I'm describing. But on day 2, the building blocks of bone scaffold on, but they break off right away because they train again the next day. So to get the new bonds, chemical bonds, to be scaffolding and robust, you need a 5-day turnover. So that's why when you look at the grand old men of powerlifting, you know, I think of in your country, people like Andy Bolton. Andy Bolton was the first guy in human history to deadlift 1,000 pounds off the ground. Andy Bolton's a Brit. I know Andy pretty well. and when you watch Andy train, it's not, you know, balls to the wall, heavy training every day. That's how you create trauma that runs ahead of the rate of repair. So bone callousing requires a 5-day turnover. You're starting to see. So with Brian in the book, even as damaged as he was, he committed to a year of bone callousing, and that would start with, say, just a loaded suitcase carry, a very modest kettlebell. So here's the guy who had the world record in squats in 2 different weight categories, doing spine hygiene, the big 3, and then a loaded carry, very modest, for a year. But every 5 days he would do the carries.
That's commitment.
Well, if it's professionalism, that's why he's Brian Carroll. You get a younger guy like I used to be, and like you, it sounds like you used to be. You don't listen to that. Oh, training stronger.
We've all had to learn the hard way.
You have to learn that the hard way, exactly. So there's a little bit of a story behind that with the mechanism of piezoelectricity and how bones remodel and how you really build. It's easy to build muscle strength. That's the easiest thing you can do. It's then building the joint integrity and then the wisdom of motor control to know how to handle 1,000 pounds down your back and steering that thrust line, as we call it. You can't tolerate being out 2 millimeters. It's a big deal if you're under 1,000 pounds.
It's been a real honor talking to you, and thank you very much for your time.
My pleasure, Fred.